So I'm George Diaz. I'm one of the infectious diseases doctors here. I'm a medical director for antibiotic stewardship. What we're going to review today is the use of inpatient antimicrobials, so all IV antibiotics. Do we have students today here? Or is this one student? What year are you? Oh, 2 students.
Just finished my first year.
Oh, okay. Oh, 4th year, great. All right, so we'll start with the students. How many classes of cephalosporins are there? 5. Most people say 5, some people say 7. We'll stick with 5. The board was a little small for 5, so we'll do 5th last, sort of its own little category. All right, so this is all IV antibiotics. So can you guys name a first-generation cephalosporin?
Cefazolin.
Cefazolin, good. Cefazolin. Second generation?
Cefuroxime.
I'm sorry?
Cefuroxime.
So in the hospital we use cefoxitin, and also occasionally cefotetan. How about third generation?
Ceftraxone.
Ceftraxone and
Cefotaxime.
cefotaxime, and then ceftaz. Fourth generation?
Cefepime.
Cefepime, good. And then fifth generation?
Ceftaroline.
Good. All right. Ceftaroline. Okay, so what organ system do we usually treat with first generation cephalosporins? What part of the body? Skin and soft tissue, yes. Skin and soft tissue infections. So what organisms? Staph and strep, so very active against staph and strep. How about enterococcus and cefazolin? Any ideas? No, not at all. So none of the cephalosporins treat enterococcus. And E. coli, staph, and cefazolin? Yeah, it's sort of like maybe 2+ here. Pseudomonas? No. Anaerobes? No. Okay. So this is an antibiotic we use quite a bit. So 2 major points. What can you tell me about dosing in cefazolin? Any ideas? What's sort of unique about cefazolin? How about someone who weighs 300 pounds? What's the right dosing?
12. Okay.
Any ideas?
3 grams.
Right, 3 grams.
Yeah.
And this is actually something with the floor pharmacists we see a lot. So there's a lot of big people here. So 3 grams, right, every 8 or even every 6 for over, I think, 130 kilograms, right? Good. What organ system do we use cefoxitin and cefotetan for? Any ideas? What part of the body?
I see it a lot for like a prophylaxis, like surgery for like abdominal.
Abdominal. So what 2 organisms do we usually care about in the belly? Of these on the menu here. I'm sorry? E. coli? Yes. And? Anaerobes, right. Pretty weak against everything else. So, any drawbacks on cefoxitin and cefotetan lately? In the last 5 years? I'm sorry?
Shortages?
Shortages, yeah. Any others? The drug itself?
Resistance?
Resistance, right. So it's losing activity against B. frag, which is a group of anaerobic organisms. And so a lot of places are going away from this. And actually, we've thought about actually getting rid of this here locally for pre-op because of that reason. Okay, moving on to third generation. What is the difference between cefotaxime and ceftraxone?
Ceftraxone is dosed more frequently, and it's often on shortage.
Okay, so...
Less biliary sludging used in pediatrics.
Biliary sludging. So who is that important for?
Kids under 28 days.
Yeah, so neonates. So this is peds, this is adults, right? What about their indications? Are there any differences in indication?
Those are indication for meningitis, so that's good.
They both basically have the same indications. They're almost identical agents. All right, so what organ systems do we use third generation cephalosporins for?
Herniated, strap,
So we use it a lot for community-acquired pneumonia and like UTI, right? Okay. So, not that great against staph. It's basically the drug of choice for pneumococcus. Oops, should go down here. How about E. coli? Pretty good.
Good pattern here.
Yep. Pseudomonas?
No,
No. Anaerobes?
no.
No. Exactly.
Enterococcus.
No, not active against enterococcus. All right, so this is one of the agents that we actually want to reduce length of therapy in pneumonia. Right, we use it a lot for pneumonia, acquired pneumonia. So what's the normal duration of therapy for pneumonia? 5 days, right? So we've actually defaulted an order set for 5 days. How can we make it shorter? PCT, right? So, and what is the cutoff for a negative PCT? 0.25. Right, so, and ideally on the floor pharmacist, if you see someone on ceftriaxone, cefotaxime, almost everyone should get a PCT. The facilities that use this 90% of the time in their pneumonia patients, they have a lower length of stay, lower duration of therapy. So this is one of the agents we'd want to target for reducing overall antibiotic utilization. All right, ceftaz. Why do we care about ceftaz?
Because it's not
Pseudomonas.
good for gram-positives.
Yeah, it's pretty weak against gram-positives, but it's active against Pseudomonas, right? And it's similar to ceftriaxone against E. coli, and then it's fairly weak against staph and strep, right? Something like this, and not active against anaerobes. The only reason we ever use this is basically for hospital-acquired infections. All right, cefepime, staph and strep. Yeah, great. E. coli, Pseudomonas, anaerobes.
No,
No. All right, what can you tell us about cefepime use at Prov Everett?
we use a lot.
Hi.
How about compared to the other, well, we have data for like the other 30 hospitals in the system. How do we compare?
Top of the list.
Number one,
Don't we use as much as the other 29 combined?
we do. We use a lot of cefepime. So we don't use much of other agents, but we use a lot of cefepime, and it's probably the biggest reason we use it is hospital-acquired pneumonia. Right? Same sort of thing. We need to get the docs using PCT for all these HAPs, right? And what's the length of therapy for a HAP? 7 days, right? So the ICU has the longest use of vanco and cefepime, I think, maybe system-wide. So these guys are on vanco and cefepime for 10, 12 days, and they don't need to be on it anywhere near that long. So we have to work with our ICU. All right, ceftaroline. What's it good for? MRSA what?
Skin infection.
Yeah, it's only FDA approved for MRSA skin infections, right? Nothing else. And we almost use, can't remember the last time we used this. All right, what's the cost of all these agents? Classes 1 through 4 here. Cheap, right? I think ceftriaxone is like $2. People get cefepime for under 20, probably 15 a day or something now. So they're all cheap. Ceftaroline, the idea is,
Probably expensive.
it's over $100, it's gotta be.
Yeah, I think it's like 60 to 80 a dose, but it's BAD, so it's over 100 a day.
Yeah. What's our cost of vanco? Under 10 a day.
What about with the monitoring? I don't know what the lab costs.
You know, another 10, 15 bucks or something is pretty cheap. The toxicity though is a bigger issue, right? All right, any questions on the cephalosporins? Good, let's move on.
I just have a question about ANSTEF.
Yeah.
So when I've looked into the obesity,
Yeah.
saying all the literature is on pre-op
Yeah.
patients, so it's for this kind of one-time sort of a couple-time dose thing or just for perioperatively. So how do we know that it's,
How do we know that the dosing is correct? That's a really good question.
yeah, I get that correct is perhaps a
What's that?
hard, well, correct is hard to say necessarily for any of this stuff precisely, but I just was wondering where,
How do we know it works for
Yeah.
5 days as opposed to 1 day?
yeah, I worry about it, if it just hangs out in their tissues or something, or it ends up becoming toxic over time, those kind of questions.
So the things that we would worry
Does
about.
it clear out of them or something? Or
The things
does
we
it
worry about
matter?
with beta-lactams in general would be 1, seizures, right? We don't see that in cephalosporin vaccine. 2, you occasionally see renal insufficiency with some beta-lactam, especially in zosine, right? And then the third issue is bone suppression. And you occasionally see cephalosporins. We haven't seen that at all with obesity dosing.
And what is the timeline for the bone marrow suppression? Like, when would you expect it to be, if
Minimum
you wanted
2
to
weeks.
finger that drug?
Minimum 2 weeks.
Okay.
Yeah, pretty much anything that suppresses the bone marrow usually takes a couple of weeks, because it's sort of like an immune-related response. So the Zybox, everything basically takes 2 weeks. They will do it too. It's not ever immediate. It always takes a couple of weeks. And if they're on nothing else, and we see these patients in the office, and if they're on just, Vanco, and then their white count starts to drop, we stop it. It'll bump up within back a few days. So we haven't seen those side effects. So there's issues with sort of big boy dosing of cefazolin. So I think it's safe, and I think the kinetics and pre-op have been worked out, so sort of extrapolating it for a couple of weeks probably makes sense. Okay, any other questions?
So just to clarify again, and so here, with patients with, you said over 130 kilos, you prefer for us to do 3 grams QA on them?
Yeah.
Okay.
Yeah, and a lot of it depends too on how bad the infection is. If it's really bad, we generally try to push it as high as we can safely do it. Okay, penicillins. What are the classes of penicillins? Penicillin, good. Next class,
Anti-staph.
sorry?
Anti-staph.
Anti-staph, good. So which are those?
Nafcillin.
Mhm.
Penicillin.
And then methicillin, right?
Dicloxacillin.
That's PO.
Oh,
I'm just talking about IV. Okay, good. Next class.
Carbapenems.
We're going to talk about those separately. These are straight penicillins. Aminopenicillin's good. Someone remembers their lectures there. So what's the one aminopenicillin we use?
Ampicillin.
Yeah, AMP, and we'll say Amsilbaxan for this. Okay, and then the last class are, anti-pseudomonas.
Yeah.
Whatever penicillin's gonna be.
What's that?
Whatever penicillin's gonna be.
Yeah, exactly. Okay, how good is penicillin against staph infections? It's about 5% active, so and we don't even test it. So if you happen to be somewhere where they actually test for penicillin and it's active, you can actually use it, but most of the time it's not. How good is penicillin for streptococcal infections?
Good.
Good.
Really good.
Does anyone say bad? I'll toss out a couple of strep. How about strep pneumo? Would you want penicillin for your pink-heart pneumonia?
If it were sensitive.
If it were sensitive, but there's plenty of resistance, right? Then how about Viridans? Viridans strep. Would you want straight penicillin for your Viridans infection?
Yes.
Risky. So these two have penicillin resistance, right? So generally speaking, so the grouped strep, what are the group strep? What's a grouped streptococcus?
Pyogenes.
So group A is Pyogenes, B, C, all the way to Z, right? All the group strep are generally sensitive to penicillin. The non-group strep, which usually refer to strep pneumo and Viridans, have penicillin resistance. So it depends, plus minus, on what kind of strep we're talking about. How about Enterococcus and penicillin?
No. Maybe penicillin.
So the no, I'll give you guys a clue here. Group D strep equals Enterococcus.
Oh, following that logic, yes.
The answer is yes. So penicillin shows the drugs of choice for enterococcal infections, right? So penicillin, ampicillin, and piperacillin are all active against enterococcus. These are the drugs of choice for
So why does our lab always report it out then that it's ampicillin? They never say penicillin.
We don't test for it.
And well, that's the only reason why?
Yeah, and actually, ampicillin is a drug of choice, so we don't want people using penicillin. What's the drawback of penicillin? The biggest drawback for the pharmacy?
The infusion, just like, you mean like how often you have to give it?
Yeah, it's what's its half-life?
Short.
Like super short, it's like an hour, right? So we do it by continuous infusion here. And how much do you guys like making up continuous infusion?
I don't care, text me that.
That's it, no one likes it, the nurses don't like it, the IV doesn't like it. So we don't use a lot of straight penicillin. And that's really the only reason, otherwise we could use penicillin instead. But we generally use ampicillin here, it's every 6 hours. And actually, in the outpatient setting, we'll set these up as continuous infusions of ampicillin. Make it easier for the patients to dose every 6 hours because they have to wake up at night. Okay, E. coli and penicillin? No. Pseudomonas? Anaerobes? Yes. This is why dentists like this agent, because it's active against strep and anaerobes, and that's what's in your mouth. Right? So why do we break out the penicillin here at the hospital? It's the only one reason. Why do we break out straight penicillin here? It doesn't happen very often, maybe once every 2 or 3 months or something. Any ideas?
Dental abscesses?
Sorry?
Dental abscesses?
No, it's actually, so necrotizing fasciitis. Thankfully, we don't see that very much. And what's probably the most common organism that causes that? Yeah, group A strep. Group A strep. So this is about the only reason we ever pull out straight penicillin in the inpatient setting. Okay, so let's move on to the anti-staph antibiotics. How good is, actually, what are the differences between NAF, ox, and methicillin? Are they the same or different? How often do we use methicillin around here? We don't, it's pretty unstable, so you can't use it. And actually, you can put it in a Kirby-Bauer disc, and it maintains its stability, so you can do testing with it, but you can't use it for therapy. How about, what are the differences between nafcillin and oxacillin? Any ideas? Same or different? Basically, these are equivalent. So why do we pick one over the other? Cost, basically dollars, right? So they're both generic. Actually, I think they must be difficult to produce because these are expensive. These are also probably over about $100 a day. The last time I saw it was like $150. So I don't know why they're expensive. They must be hard to produce. So what do we use it for? MSSA. And that's basically it. This is basically the drug of choice. So when would you, as a pharmacist, recommend a doctor who's got someone on cefazolin to switch to nafcillin? Where? Where is it with the key? So cefazolin gets in the bloodstream very well, right? So it's not endocarditis. So where does cefazolin not get into very well? It doesn't. The cefazolin doesn't get into the brain, CSF, and spine all that great.
I have a question then, going back into the cephalosporins.
Mm-hmm.
So, CNS penetration with cephalosporins. So, cefotaxime, ceftriaxone end up being, are they actually good, or is it just that you have an inflamed meninges? This is like I always wondered about this, like what's different about them than ANSEP? Like,
That's a really good question, actually. I don't know the answer to that. They get in the meninges, in the CSF without inflammation. The only one that we really care about in terms of inflammation is vancomycin. You pretty much clearly need inflammation for it to get in there very well. But the cephalosporins as a class, cephalosporin gets in there very well. I think ceftaz gets in there very well. Most of the cephalosporins get in the CSF very well. Cefazolin doesn't. For some reason. I don't know. Good question. So if you have someone who's got MSSA in their brain, CSF, or spine, those are reasons why the doctor should consider switching to nafcillin. So besides the cost, why don't we use these? We use a lot of cefazolin. Why don't we use more nafcillin besides the cost?
Frequency.
Yeah. It's hard to do this at home. Nobody likes every 4-hour agents, and this is one. I think we can do it, continuous infusion, but it's not that straightforward. Okay, moving on to, and these are active against strep, but why would anyone use them for strep? They're not active against Fishcoccus, nothing against, basically a pure gram-positive antibiotic. All right, Amsulbactam, staph and strep. Good. We give it like 3 pluses. E. coli.
Here, no.
That's a good answer. Here, no. So we're going to give it 2 pluses. I think it's around 60. But if it happens to be a sensitive E. coli, you can use it. So we don't use Amsulbactam generally for impaired treatment of intra-abdominal infections, unless you know it's likely a sensitive organism. How about Pseudomonas? No. Anaerobes? Yes. Oh, this is a broad spectrum antibiotic. If it wasn't weak against E. coli, it'd be great. How about Peptazo? Staph and strep.
Yeah.
Good. E. coli,
Yeah,
Pseudomonas,
yeah,
anaerobes.
yeah.
Actually, we've basically quashed Zosyn use here. You know, it's more expensive. It used to be way more expensive, actually. It was probably double the cost 5 years ago. The cost has come down, and now Zosyn's only more expensive by like $5 or something, maybe.
Yeah, it's not that bad. Once a lunch and errands, it's not that bad.
Yeah, so we don't use very much. It's mostly all cefepime around here. Good. Any questions about the penicillins? All right.
Hey, George,
Yeah.
assuming pip/tazo is being used appropriately, should we be using it at the anti-pseudomonal regimen, dosing regimen?
We should, well, the rest of the system does it basically by extended infusion. I think, do we do it here? You didn't-
No,
No.
no.
Paul blocked it. This is like the only hospital in the whole system that doesn't do extended infusions of this, because that actually is probably superior. And the reason cited back then was the pump issue. It would be holding up our pumps, and I don't know if we've looked at that again or not. It's probably not that big of a deal. Anyways, it's
I don't
use a
hold
little
up our pumps
bit.
any more than in any other institution, though. I mean, if you need another, you know, I mean, they're gonna have the same issue with having to have more lines on patients or using pumps or anything like that. I mean, just because we happen to have BARD pumps here, it doesn't mean we have to use them, does it?
So we revisit that, but yeah, so so the protocol embedded in EPIC is actually extended infusion, and that will treat Pseudomonas. So ideally, we would use that if we're gonna use it.
We could revisit it.
Okay, carbapenems. What are the carbapenems? Miro, heard, I think I heard Dory. Enemy. All right, there's just one line, so there's 2 columns. So we'll start with you, Emmy, right or left? You can put on either side. This is the first one. You want to put Emmy on the left? Okay. Emmy on the left. Erda, right or left?
Could be the other side.
The other
Doesn't
side.
have her
Okay.
pseudomonas.
Good. Dory, right or left? Sorry, left? Good. Miro, right or left?
Left.
Good. And so what's the difference between these agents? Pseudomonas, right? Big fat 0 for erdopenem. They're all sort of plus minus for enterococcus, and we don't do enterococcus testing for carbapenems here. We possibly could, but there's almost never a reason to do it. How about for staph and strep, these agents? Yeah, they're active. Give it like 3.5, something like that. Never really use them for that much. How about E. coli?
Yes, yes,
4 pluses, pretty much. Pseudomonas, other than erdopenem.
yes,
Yep. And anaerobes,
yes.
very active. So when is it appropriate to use a carbapenem?
ESBL producing organisms?
Yeah, ESBL. So what is an ESBL exactly? What does it confer resistance to?
It's an extended beta-lactamase, so beta-lactams.
Right, so penicillins and cephalosporins, right? And there's a screen on there, so you're going to read out with E. coli or CLEB, it'll say ESBL screen, positive or negative. If it's positive, generally we use carbapenems here, although if you wanted, we could do Kirby-Bauer testing, and the interpretations on, so automated interpretations of ESBLs isn't totally reliable, but occasionally and this isn't like the foolproof, this is just an algorithm. So there are sometimes beta-lactams that will be active against whatever organism despite a positive screen. So if we had to use a cephalosporin, we could actually ask the lab to test it. But here, for the most part, it's almost reflexively, we'll just use a carbapenem. So what are reasons here where it's appropriate, besides an ESBL, to use a carbapenem? This is number 1.
Meningitis patient with penicillin allergy who's over 50 or has risk factors for listeria.
Yeah, so that's a good point. So, so if someone has a beta-lactam allergy, actually, I think the alternate agent is Bactrim, but you can use carbapenems as well if you had to. And Bactrim gets in the CSF better than carbapenems do. So the other ones is like, pancreatic abscess, right? And occasionally febrile neutropenia. If someone's got severe sepsis, usually, oftentimes we'll do, you know, a carbapenem in people that are really sick with febrile neutropenia. But that's about it. In reality, we use these agents probably more than we should. We end up using a lot of ertapenem in the short stay suite because it's once a day, and for our patients that need to come here just for one dose per day, we'll sometimes use it. Otherwise, system-wide, I think we use relatively low levels of carbapenems compared to everybody else. Yeah. Good. Any questions on the carbapenems? Let's move on here. We'll talk about the fluoroquinolones. Okay, we're gonna. So what's bad about the quinolones?
Resistance.
So badness. So resistance is one.
Delirium and elderly
Side
people.
effects.
So we'll say delirium. What else?
C. diff.
C. diff, I'll put number 2. 1, 2, 3.
Tendon rupture.
Number 1000, tendon rupture. You almost never see that, but, and then the third, probably biggest one is a QT issue, right? So much so that the FDA has basically advised not to use quinolones in what settings? When should we not use quinolones? For what indications?
UTI.
UTI, so lower UTI, bronchitis, and sinusitis. And actually, we just went live with a BPA to the docs, that if they order a quinolone and they ensure UTI, bronchitis, sinusitis indication, they get a little alert saying, this is ill-advised, don't do this, please.
What do you recommend then for males?
Probably a cephalosporin here, because our E. coli, which is what you care about,
Even
is
if they were worried about like prostate involvement, that's what I always had learned was that if you're trying to get into the prostate, you need some
prostatitis is
kind
not
of
UTI.
Well, no, but I mean sometimes what I'll see is they're like, okay, it's a guy, they have some sort of urinary symptoms, and they are also wanting to kind of deal with that kind of stuff.
So prostatitis is different than a UTI. They're completely different, distinct diagnoses, and hopefully the docs know the difference, right? So how do you diagnose prostatitis? Any ideas? So a rectal exam actually is extremely helpful because the prostate's generally very tender, right? And so the prostate exam, very tender, the guy jumps off the bed, my prostate hurts, don't do that. Then that's probably prostatitis. The second way is by CT imaging, right? And generally speaking, people with prostatitis are much more ill in general than people with UTI. They have sepsis, high fevers, and persistent, and those people should be imaged because they can have badness in their prostate. So we're not talking about prostatitis here, we're specifically talking about UTI. And if it's just a UTI, then here, something, like even an oral cephalosporin is probably okay. And our Keflex sensitivity is actually pretty good.
They're
for
really
coli.
good. They're better than fluoroquinolones anyway.
Yeah, our sensitivity to E. coli to fluoroquinolone is like around 80% now. It was around 78 a couple of years ago, and we've sort of knocked the use of quinolones down, and our sensitivity has actually gone up a couple percent. So this BPA started going live at the end of June, and so we looked at 3 weeks of data last week, and we've decreased our quinolone use for this about by a third. So that helps, and it's almost all in the ED. So do we have, who's in the ED the most? We need to go down there, and there's people that we can see why they're declining, and they kind of look like they're bogus reasons, why they're overriding the BPA. So some people are just having a hard time learning. Okay, so C. diff. How bad does this trigger C. diff? There's a little graph here.
Like from the studies, like odds ratios and stuff.
Yeah, odds ratio.
I don't know, I've seen stuff reported like 10, 12, those kind of things, but it's similar to cephalosporins on certain studies that I've looked at, so.
It can be as high as 32. It can be
Yeah.
pretty high. So actually, it's all over the map, right? So some people say that it doesn't trigger C. diff, but I'm sorry, clindamycin is number 1. Fluoroquinolones are in the range of 14 to 17. How about cephalosporins?
I've seen cephalosporins that are not that much below that.
Yeah, 12. And actually, there's a difference. So what are the high-risk cephalosporins? So which were the ones, among the cephalosporins, which trigger C. diff the most? So third and fourth, far more than 1. So if you can get people on cefazolin rather than third and fourth, will reduce the risk. So cephs, right? And what's next? So next are the penicillins. and around 4 as a group, but it's similar to cephalosporins, there's a different.
All those are pretty low, I think, aren't they?
Yeah, and then below this, actually, number 2 is PPI, or odds ratio of 2 is PPI. So they actually behave like antibiotics, and we just went live with indications for PPI. And so what we want to avoid with PPI is, so if you see PPI plus C. diff, try to get them off on some H2 blocker if possible, H2 blocker, or PPI and a high-risk antibiotic. And the high-risk ones are 3rd and 4th generation cephalosporins, beta-lactam, beta-lactamase inhibitor, beta-lactams, quinolones, and clindamycin. So if you see a PPI and a high-risk antibiotic and PPI C. diff, try to get them off of these, especially if the indication is GERD, right? That's basically what's happening right now is that almost everybody is entering an indication of GERD, right? And so these are all targets, right? So if the doc doesn't know, they're hitting GERD, right? And if you have GERD and you're in this sort of a scenario, get them off of that PPI. And that's something you can put on a sticky note. Hey, please, can you get this guy off of PPI? We even talked about doing this as a protocol, right? Through P&T, which would make your lives even quicker. You just automatically switch it to a H2 blocker. There's a lot of PPI use here. And then
A lot of order sets.
we've taken it off all of the relevant order sets. And the use was not driven by order sets either. It was 99% of it was a la carte ordering. People don't even know why they're on PPIs. And then the ones that don't cause any C. diff are basically Bactrim, tetracyclines, macrolides. These have pretty low rates of C. diff. So here we've targeted quinolones quite a bit through our ATMS program, and I think we're pretty low overall with quinolone utilization, but they're still in appropriate use. Okay. Resistance and quinolones. Okay, are all the quinolones the same in terms of resistance?
No.
No, they're not. Which of the cephalosporins is most likely to develop resistance in vivo? It is?
We're just talking about the 3 that are on the market.
Yeah.
Cipro.
Cipro is the worst.
All of them.
Next worst?
Levofloxacin.
Levo, and then Moxie.
Moxie, because doesn't Moxie actually hit like 2 sites or something?
Yeah, exactly. So these unfortunately have a relatively narrow therapeutic window, right? So what happens if we try to increase the dose to overcome resistance? Yeah, people get a QT prolongation and then they're dead, right? So we can't really modify the dosing that much. So you guys all know what the MIC, you guys know what the MPC is. So basically the dose required to prevent mutations from occurring to result in resistance. So if we could just crank up the dose of Cipro to some monstrous big dose, we could prevent resistance from happening, but it's unfortunately not going to be dead. Right? So we can't do that. So we're stuck. Right? So neither Cipro nor Levo get to the MPC, although Levo is better than Cipro. And Moxie actually gets above the MPC, at least for strep pneumo. And so you're right. So this is basically thought to be 1 step, 2 steps. Right? So let's say we're talking about a Staph aureus. And initially the infection is sensitive. You put them on, let's say, Cipro. Infection doesn't get better, you recheck it somewhere at some other site, and it looks like this. So what's happened here? So this is strain number 1 and strain number 2 in the same person.
Selection.
Yeah, so you've basically blown this out. You've mostly blown this out, and you've mostly blown this out, right? So then, you can try to use Moxie, but it's going to start behaving like Cipro. So in serious infections, what do we do to prevent this issue from happening in serious infections, like Staph or Pseudomonas?
Pseudomonas, they take double coverage.
Yeah, this is where the whole idea of double coverage came about, right? So if someone has this, let's say they have a real bad Staph osteo, and they're gonna need, 6 or 8 weeks of treatment, and you can't use a beta-lactam for some reason, and you put them on Moxie plus Riff, right? How many mutations do you get Moxie? 2. What do you get for Riff? 1, 3, right? 3 is a magic number, and I think.
3 is good, I mean, that's the
3 is a
whole
magic
heart
number.
thing with HIV.
Yeah, and TV and everything else. Okay, so how about Piptazo? Piptazo plus Cipro. My pen is dying here. Piptazo and Cipro.
Should be 3.
You get basically 1 here, 1 plus 1 for synergy. And some agents are synergistic, right? So they drive both the MICs way down if you use them in combination. So it's common between beta-lactams and quinolones and beta-lactams plus aminoglycosides. Good, so resistance is an issue. Otherwise, so we've just sort of discussed all the bad stuff about quinolones, but we can actually use them when we have to. Right? So let's look here. We'll divide these up here. All right, so this will be Cipro, Levo, Moxie. How good against staph and strep? Cipro, staph and strep.
Maybe 1 plus,
Yeah, about 1 plus. How about Levo?
have more pluses.
Yeah, a couple more pluses probably. Actually, Levo is good, right? Because we use it for chronic pneumonia. It's a good strep antibiotic. How about Moxie? Yeah, better for staph, not the same for strep. Enterococcus?
No, super progress.
Plus minus here, and not really here. So if you're super in a bind, and someone's got an enterococcus UTI, and you really can't use anything else, you can have the lab unsuppress it. It's a suppressed result, so you call the lab and they'll suppress it for you.
It shows up on the report then.
Once you ask for it to be suppressed, it'll show up. But it won't be shown because we try not to drive people to use this agent for enterococcus. But it can be active. Cipro and atypicals? Any ideas for Cipro? Actually, this is no, not at all, 0. Right, so hopefully you're not seeing a lot of Cipro for community-acquired pneumonia. Yeah, hopefully not. Occasionally we've seen it. How about Cipro and E. coli?
Yes.
Yeah, we'll give it 2 pluses. This is about 80% here. Something like that. Pseudomonas? Yes. Give it
We'd be the
2.5.
same following that same logic, 80%.
Yeah, about that. Anaerobes? No. Okay, what's the difference between Moxie and Levo?
Different anaerobes on Moxie, or at least some anaerobic activity.
Yeah, the difference is right here. All right, so Levo is activating Pseudomonas. Moxie's not. Moxie's activating against anaerobes, and Levo's not. Otherwise, they're basically the same. That's basically it. We don't use any Moxie here, actually. I don't even think, do we even have any down in the pharmacy?
Not in our pharmacy, they do in the outpatient, I mean, it can be prescribed, it just, we don't have it here.
Is it even generic? I didn't even know it was generic yet.
I think it is.
Is it generic? We haven't looked at that in a while. Levo went generic and we basically did away with Moxie. That was like 5 years ago. All right, any questions on the quinolones? All right, let's move over to...
I have a question about the quinolones, I mean, because there are some attractive features to them, like
yeah.
little tissue penetration thing and like bioavailability and stuff like that, I mean,
Yes,
because I mean, there is some issue like with like the ER, when the ER is really busy and they're giving people like a first dose antibiotics and then they want to get rid of them, rather than starting an IV and stuff, go faster. I mean, like, could that be an argument to be made for giving someone a quinolone versus starting an IV and holding up the room longer? And
It depends what your indication is. If it's just a UTI, then the answer is no. Right? And that's basically all there. We're not seeing quinolones used much for sinusitis and bronchitis, almost all for UTI. So if that's what they're using it for, the answer is no. And it depends what the infection is, right? If it's an intra-abdominal infection, they shouldn't be using basically any of the quinolones because it's not active enough against E. coli. If it's prostatitis, yeah, you can make an argument for it. If it's pneumonia, if it's pneumonia, we should be giving people ceftriaxone. You know, pneumonia is probably going to be one of these ones that gets added to the list of not using Quinlox, I would imagine, because it's used so commonly for CAP. So I would say favor using ceftriaxone, and that's indication in our guidelines. I don't think there's any difference. There's no difference in our guidelines between ED and inpatient use of these antibiotics. And the ED reviewed our guidelines, so they apply to the ER.
I'm just thinking, because if they're not being admitted though, then.
We have recommendations for, I think, outpatient stuff in our guidelines, even for pneumonia, I think, for low risk stuff. We could discuss that further, but if anything, I think we're trying to drive down the use of Quinlox. Any other questions? All right, let's move on to the anti-staph antibiotics. So what are our anti-staphylococcal antibiotics? The MRSA, I should say.
Vancomycin, daptomycin,
Vanco, Dapto,
Amazolid,
Zylox,
So,
ceftaroline.
ceftaroline.
oh, that's right.
Doxycycline.
We'll move, we'll talk about, we'll say down here, we'll say PO. So this is going to be, so PO, Clinda, Doxy, Bactrim, Zylox, what else?
Baxdela.
What else?
Oh, yeah, that's what I'm saying. There's Baxdela.
I don't think we have any other, we don't use any other anti-MRSA agents in the hospital here. Okay, so we already said this is about $10 a day. What's Dapto per day? What we pay for it is around 500, I think, roughly, right? We should know. Dapto's pretty expensive. 350, I don't know, somewhere in the hundreds.
It's much less than
We should ask Jennifer.
that.
All right, I think it's still expensive. How about IV Zylox? I'm sorry?
Yeah. IV's cheaper than PO, strangely.
By a lot.
Yeah.
This is still, I'm pretty sure, still over $100. This is around 150. And we're going to talk about dalbavancin soon. We'll just tack it on over here. Dalbavancin. It may go on formulary here for outpatient use only.
Where do you put tigacycline?
Yeah, we can put tigacycline. We don't use it for MRSA infections though, per se.
Weird things, huh?
Yeah, someone, like multi-drug resistant Acinetobacter is probably the most common reason why we use tigacycline here. Or like some sort of severe trigonal infection where they got a bunch of allergies or something. We almost never use tigacycline. I think you looked it up 4 times a year or something, or
Yeah,
tiny.
it was small.
Okay, so cheap is good for Vanco. What are the drawbacks? So monitoring, so renal. Right? So when do you have to push the trough? What are the indications for pushing the trough?
I mean, like increased?
15, 20.
CNS infections.
CNS.
Endocarditis, osteomyelitis.
Blood infections,
Osteo.
osteomyelitis, that's basically it. Right, so blood infections or endocarditis. So the other major sort of drawbacks is, so red man, right? So if we can get them to slow the dose, almost everyone tolerates it if you slow it down over 3 hours. And with some Benadryl.
How often are people actually allergic to it? Like, because I mean, it seems like you see people with these infusion reactions, but it seems like there's not really a lot of actual,
True allergy, 1%.
yeah.
Small. And we do see it occasionally, but it's really small. Bone marrow suppression occasionally.
There's one of those,
And
like,
then
more,
tinnitus. We actually see tinnitus quite a bit, actually, surprisingly. It comes up a fair bit. But these are all, this takes a while to reverse. People have this for weeks after you stop the agent. This resolves quickly, this resolves within hours. The renal issues do persist for a couple of weeks as well. But we can usually manage all this. When should you be worried about renal impairment? What are the 2 key findings for someone who's at risk for renal impairment from vancomycin? 2 flags.
Low urine output.
So yeah, so decreasing in urine output, that's one. Decrease urine output. This is so if you got somebody on Vanco That's one thing to think about, is if your output decreases.
It's easy, I mean, it's hard on the
It's
floors.
harder on the floors. That's one. The second one is when they're on more than about 4 grams a day, or 4.5 grams, somewhere in there. You know, you gotta.
CT imaging, insides and stuff.
Exactly, these people, you know, sort of that's a big dose of vanco. And so, we're only checking trough. That's something maybe we should think about, actually. You know, the way we're checking troughs now, this seems to happen within the first 2 weeks of treatment, pretty much. So if you see their creatinine go up at all, whether you're up a drop, I would check troughs more frequently, because these are the people that are the highest risk. It's usually a young person with a big dose of vanco whose creatinine goes from 0.8 to 1.2 in a couple of days. That's actually a big change, right?
And then you
those
go
people,
ketorolac and then they.
right? They have a bunch of pain. They get Toradol, whatever. And they get a CT scan, and they have a tendency to develop renal failure. Okay, side effects with problems with Dapto. Rhabdo, so CPK, we check those weekly, or if they say their muscles hurt, check it. Anything else?
Does it penetrate lungs?
Yeah, no lung penetration. So we can't use it for parenchymal pulmonary infections. Right? That's really about it. It's otherwise a fairly clean agent.
How often do you actually see the
Actually, go ahead.
CPKs go up?
1 to 5% of the time. It's really uncommon.
And when somebody's starting on it, is anybody who's starting on it, you want to check that in a week?
Yeah, anybody. It can happen to anybody. The other thing is, there are reports of failures with Dapto. That's sort of long term. So when someone's been on for vertebral osteoarthritis for 5 or 6 weeks. So the ID docs here, so I generally start people on like 6 mg per kilogram. A lot of the other ID docs push it to 8 or 10, especially for spinal infections. So when you're up at sort of the bigger doses, you got to be more careful about this. And the reason for increasing the dose is because of the concern for failure with Dapto.
So it is a dose-dependent toxicity and not just some sort of like weird thing that just randomly happens?
Yeah, it can be dose dependent, yeah.
Hey George, so the Dapto is 414. 340B it's only $50, and that's why we only use it in the infusion suite.
It's only $50 for 340B. Not everyone gets 340B dose.
Right, but in the infusion suite we can usually do. Then Zyvox is 30, and Septerline is 140.
So Zyvox for
IV
inpatient for IV is $30 now?
$30.
Wow, that's a big drop. That almost makes me think if we should be using a lot more Zyvox IV for soft tissue infections. I mean, it's going to be, you're talking about $30, you know, for IV Zyvox. Yeah, we'll see. Something to talk about, actually. I didn't realize the price had dropped so much.
It's easy.
And it's easy, for the most part. What are the drawbacks of Zyvox?
SSRI, serotonin.
Yeah, so everyone's on an SSRI, right? Actually, I had, well, that was Vori. I had one of the pharmacists check, I had Patricia check before starting Vori, someone had mold. I wrote a pharmacy consult, please see if there's any Vori interactions. And she wrote back, there are 6 interactions in the chart with Vori. And so everyone's on an SSRI or SNRI or trazodone or a tricyclic. I mean,
In your experience though,
everybody.
is there a type of patient where you are really more likely to see that happen? Is it somebody who's on like multiple things and then they get like a dose of sumatriptan and then...
It's not like single dose stuff. I mean, this is like people that are on chronic. I mean, that's a problem, right? How quickly to taper somebody off of their SSRI is a hassle, right? Because I don't think you can do it abruptly, unfortunately.
No, they have
So-
withdrawals, especially with the shorter half-life ones like Paxil and stuff.
Right, so usually we rely on you guys to help us say, okay, when can we start someone on Zyvox? The answer is almost always a couple weeks. We see bone marrow suppression with this too. That takes 2 weeks, bone marrow suppression. We can't use it for long because of optic neuritis. I've not seen that.
When you say long, like what kind of a duration?
Over like 6 weeks, 8 weeks.
So bottom line then with those SSRIs and Zyvox is no, or doesn't matter for short period?
If
or-
pharmacy can say stop it sort of abruptly, or at least start tapering it, and the patient agrees, because a lot of the people around here are on like 2 or 3 of these, and like, you know, you're not gonna get them off of this stuff, they're gonna go nuts. All right. Yeah, it's a problem, right? I mean, it's a black box warning, right? So you send someone out on Zyvox, they have a problem, it's clearly known, so. All right, ceftaroline, what are the good things about it? It's a cephalosporin, right? I mean, they're clean agents, right? Almost, how often have you seen like seizures with cephalosporins? Almost never, right? I mean, occasionally neurology will implicate cefepime, but they're otherwise, you know, relatively well tolerated. Any drawbacks with ceftaroline?
Use it on limited indications.
It's only for really bad skin soft tissue infections. But sometimes people use it for MRSA pneumonias if we can't use Vanco. But yeah, it's the limited indications is a problem. Dalbavancin. What's good about dalbavancin? Once a week dosing. Yeah, once a week dosing. What's the drawback of it? Last time we checked was $900. And this is not paid for, right? So if we dosed
Better
it,
than Dapto.
it's actually better than Dapto. I guess that's a good point. We could use Dalba. Well, so this is primarily used for skin soft tissue infections. I'm not. The U is using it for more indications than just skin soft tissue infections. They're using it for other stuff. So yeah, it could be cheaper than Dapto, and that's actually something to think about. If someone's going to be here forever on Dapto, maybe switch them over to Dalba because it's cheaper. But right now we're looking at using this as in the outpatient, in the infusion suite. So instead of someone, you know, getting outpatient Dapto daily, they get once a week dosing, and that way a drug user can get out of here without a line, right? You could just put a peripheral line in once a week, give them their Dalba, and then have them come back. I think in September we're going to bring it to PNT. 3A, maybe 3A. All right, orals. How much do all of these cost? What's the most expensive here now? Well, for us, it's not Zyvox, right? Because it's under $10 a day now, right, for oral Zyvox?
Keo Zyvox is still more expensive. It's more expensive than oral, than IV.
Really? I thought we looked at this and it was like $12 a day.
I can look again.
Yeah, take a look again. It'd be very interesting seeing. So yeah, if it's truly $30, then it's going to be Zyvox, the most expensive. All these are cheap, right? This is probably like $20. More than that?
No, I mean, it's more than Doxy and Bactrim.
Yeah, Zyvox we'll find out. And if it's Levo, it's actually relatively cheap, probably around 20. Okay. So drawbacks of Clinda, so the one big one. So you're 70-year-old.
How do you take it so often?
Yeah, it's a lot of doses, lots of
Lots
doses.
of pills, because it's always dispensed as 150, so it's lots and lots and lots of pills.
Yeah, lots of pills, C. diff. So in a young person, maybe you can give them Clinda, but
It doesn't interact with the warfarin, though.
it doesn't. That's a good point. What's the drawback of tetracyclines?
Don't want to give it to pregnant people, brown teeth,
Brown teeth, and more importantly, 20% failure rate.
and sun.
And then sun issues, right? But this is a big problem with these. Big problem with Bactrim.
Rash.
A lot of people get rash. Like everyone gets allergies to this. Rash, warfarin issues. Elderly will have increase in their potassium. That's not good. Increased creatinine. So you can't.
And really weird, rare bone marrow things. and
Yeah,
stuff.
we almost never see that.
I saw it once on rotation.
Really?
Yeah,
Oh, that's
I was
pretty
actually in a
cool.
bone marrow transplant clinic, and that was what one of the people was in there getting transplanted, and they think
That's
it's a
unfortunate,
Bactrim
actually, that
exposure. It's like a 1 in a million thing, but it does happen.
Yeah, that's- yeah.
Isn't it a benign increase in serum creatinine though?
Well, if you have an increase in creatinine and your potassium goes up, then it's not so benign,
Okay.
right? Because it's like, I think it triggers an RTA, and then you get hyperkalemic, I think is what happens. Do you guys remember your basic pharmacology? All right. So I think that's what happens, but we look at it. So these are all issues, but in a young, healthy person, actually, Bactrim is probably the #1 choice for a young person. An elderly person, you really have to think about it hard. Zyvox, we've already talked about the problems with that, otherwise it's a great agent. And actually, PO is felt to be equal to IV, right? So if someone should be on, so we do this actually sometimes, someone's in the house with IV Vanco and they want to leave AMA, we'll toss a oral Zyvox prescription to them, say, please take this, it's gonna come back. And the quinolones, those are like the fifth line, right, for the reasons we've already mentioned. And of the quinolones, you probably use Levo, because it's generally the cheapest. Good. Any questions on the anti-MRSA agents? Yeah.
Have you ever used the high dose daptomycin for VRE bacteremia comparing to the Zyvox?
Thankfully, we haven't had to treat that much VRE, but yeah, we would probably, if we had to, if it was resistant to Vanco, we would probably, you can actually, we have e-tests here. So we can test the Enterococcus to Dapto to find out what the MIC is, and it's generally sensitive, and we would generally use it. The alternative would be, like you said, Zyvox. We probably prefer Dapto. The reason being is that Dapto is a cidal agent, whereas Zyvox is static, and
But it has implication for bacteremia.
what's that? It doesn't have any indication for bacteremia.
Thank you.
Good. All right, thank you guys.